I'm one of the first fellowship-trained obesity medicine physicians in the world. And when I first got into the field of obesity, I would say it was grossly misunderstood. People thought I was trying to get them to target weights, and patients still feel that way. It really frustrates me because I don't think that is a one-size-fits-all approach to us as humans, and that different humans have different health status at different size. And so this was really a motivating factor as I hope to reduce weight bias and stigma and improve the health of patients that I treat, recognizing that one person can be 300 pounds and have a much better health and quality of life than someone that's much, much smaller, because we're looking at the whole person and not just one metric to evaluate them as an individual. My goal was to use actually chronic disease risk factors coupled with body mass index to determine what would be the appropriate care structure for individuals that have obesity as a disease. Body mass index is not derived from medicine or science, but it's what we use to determine one's weight status. And so let me take you back to the 1800s. Adolphe Quetelet, who was a Belgian statistician, sought to determine what was considered normal weight status for Belgian white male soldiers in the 1800s, and this became the basis for eugenics, which was espoused by Adolf Hitler to justify maltreatment of those that were racial and ethnic minorities and those of low socioeconomic status. As we move into the 1930s and 1940s, the Metropolitan Life Insurance Company decided to determine what was considered to be the weight status that would put you at risk for dying, hence the term morbid as it relates to obesity for white men and women that were insured by the company. As we move into 2023, we've noticed that this is not applicable to what we do in medicine or science, yet this arbitrary number, cutoffs, metrics that don't reflect the diversity and heterogeneity of the population have been used to determine one's weight status. It's problematic, and it doesn't really help us to understand the health status of an individual. My project sought to look at chronic disease risk factors and couple that with body mass index to determine risk of losing productivity or quality of life over the life course. So instead of just looking at body mass index as a cutoff, we looked at things like, do you have a history of diabetes? Do you have a history of high blood pressure? Do you have a history of high cholesterol in conjunction with having obesity? Because when you add these additional risk states on top, you do actually lead to poor health status. And what we found in this particular project by using a simulation model is that the earlier we intervene, the better we can improve the quality of life. I'm now currently sitting on the Lancet Commission as one of the representatives from the United States, redefining obesity as a chronic disease. And so this work will get integrated into the work that we're doing on an international level. We can have a huge impact on quality of life, healthcare costs, and these can influence policy. As someone who exclusively cares for patients with overweight and obesity, I think that we should begin to think about treating patients with obesity with the same kindness, dignity, and respect that we do any other disease process. I am often disgruntled, disappointed by my colleagues and by the general population and the high level of stigma and bias we have towards this population. It has to stop, and we can do better. We do for other disease processes, let's do it for those with obesity. I would love for you to follow me on social media on LinkedIn, Instagram, or Twitter at Ask Dr. Fatima. That's AskDrFatima. Join me on this journey as we seek to eradicate obesity around the world.